Remember, hello, yes, hello. Where's my whistle wave, folks? Hello. Hello, that's what I wanted to hear. Miss away from Timmins. You know, all my Northern Ontario folks. Yes, yes. So remember, when you hear the music, we are coming back. We are coming back and we're getting focused back on the stage. We're going to head into our afternoon plenary, but how's it going out there? We've got 83 responses on the Menti, and I do want you to use the Menti, because how otherwise am I going to know what y'all are feeling? There are, like what, how many people? 300, 400, 500, 600 people, and we have 83 responses. And so there's like tired, divine, fabulous, happy tummy. Always happy tummy after lunch. That was like such a really delicious meal. So I am going to say that one of the things that I often hear as one of the MCs is people like the energy that I bring and get you moving and grooving and clapping and whatnot. And so here's what we are going to do now. As part of our holistic approach to primary care, our holistic approach to health and well-being, we are now going to get you to move your body. You just don't get to see me moving my body up here, but we are going to get you to move your body. And what I'd like to do before we start on the second plenary session of the day, Futurist Perspectives on Health, Mental Health, and AI, is to invite to the stage a little movement with Tamara Aline Gittins. And Tamara, I just have to flip to the next part of my agenda, was born and raised in Montreal and has both Trinidadian and Vincentian roots. Tamara has always loved Caribbean culture, and from an early age, she was expressing her love and passion for culture, learning steel plan and Afro-Caribbean dance. In addition to her love for Afro-Caribbean cultural arts, she is a celebrated athlete, and in 2018 was inducted into the TMU Sports Hall of Fame for basketball. Yeah. So, from childhood to adulthood, Tamara has centered her love for culture in everything that she does. Currently, in addition to performing across the province, she finds time to be a dance fitness instructor for Taibu CHC for over 10 years and an Afro-Caribbean dance teacher providing dance instruction to children and youth. So welcome, Tamara. Thank you for being here. Come on over for the literal next steps. Yes.
Using this?
Yeah, you're live.
Good afternoon, everybody. You all can hear me? All right. So, she did such a wonderful introduction. I don't think I need to say any more about myself. So, I know you guys just finished eating, and some of you guys are still eating, but I promise I won't go extra on you. So I would like everybody to stand up. We're going to do some movement, as she said. If you guys feel like you need a little bit more space, you could find spots in the aisles around so you can move your shoulders and arms a little bit more. All right, let's start with the first track. So we're going to just march on the spot. You're going to find the rhythm. March on the spot.
Hey, girlfriend,
right. Let's march. Right. 3. So we're going to lift the arms up, reaching up. And down. Up. And down. Up. And down. One more time. Up. Shoulders, we're going to roll it back. Roll it back. That's right. Good job. 4, 3, 2. Now bring it forward. 1. That's right. 2, 3. So now, let's move it side to side. Right. Let's go side to side. Keep going. 4, 3. So now we're going to get a little complicated. These hips, let's bring it around. Right. Around. Good job. Keep going. 4, 3, 2. So now the feet, we're going to step, touch to the front. Touch, 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 touch. Good job. Keep going. Up, 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 up. That's right. So we're going to bring the arms with it. Swing it up. That's right. Good job. 4, 3, 2. Now the feet are going to step side to side. Side and center. Side. That's right. Side. Good job. 4, 3. Adding the arms, going up. That's right. Keep going. Looking good, everybody. I love it. Keep going. Side, side, side. 4, 3. So now the feet, we're going to step to the back. Back, 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 back. Keep going. 4, keep going. 3, next track. 2, 1. So now we're going to slow it down. So we're going to sway. That's right. Nice and easy. Nice and easy. Side, side. Right. So the arms. Let's sway. So while we're doing this, let's go down, down, and up, up, to the air, up, to the center. Let's do it again, going down, down, center, to the air, center. Let's do this 2 more times. Down and center and up. Center. Last time. Low. That's right. Center.
But we ain't never left
Up in the air.
And if I'm telling you, don't feel like
and center. So like what we did before, step. Right. So we're going to make it a little bit extra. Then out of bounce. That's right. Let's get that bounce. We kind of call this yanking. Let go. Right. So now we're going to lift the leg a little bit higher. That's right. Love it. 4, 3, doing the same thing. Let's turn around. That's right. Now let's turn the other direction. Now keep it here. Just here. That's right. 4, 3, 2. Now let's go back to the swing. All right. Keep going. 4, 2. Now let's move the shoulder. Side. 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 4. Reaching. 3, 2. Now let's swing it out. Right, let's swing. You guys look like a C. I love it. Nice. That's right. 4, 3, 2. Now hold it out. Back. Forward. Right. Now let's really lean back with it. Lean. 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 4, 3, 2, 1. Now you're gonna hold it right here. Hold it. Just bounce. Bounce. Those who can go a little bit lower, bring it lower. Right. That's right. Touch yourself. Right. So while we're here, let's move the shoulders. That's right. Good job. Keep going. 4, 3, 2, 1. Let's bring it. Let's inhale up. Exhale down. 2 more times. Let's inhale up. Exhale down. 1 more time. Inhale up. And hold it up, hold it up, hold it up. Keep inhaling. Keep inhaling. And now I want everybody to take a bow and exhale. That's about it.
Yes! Yes! Woo! All right.
You're welcome.
All right, all right. I wish that you could have seen all of you from up here. You looked incredible. You looked incredible. And I can already tell by all the energy that you're energized. But now, and so it's a beautiful example of how much movement is medicine for our bodies. And so I hope to see some of those amazing dance moves out tonight after the gala event on the dance floor. It's a competition to see if anybody can beat me out onto the dance floor tonight. With that, hi, challenge accepted from Miss Away. Hi, hello, hello, hi. Let's come back. Let's come back, because now that we've moved our bodies and we've had a chance to take a breath, I'd like to introduce our guest host for this afternoon's plenary, my dear colleague and friend and chairperson of the Alliance Executive Leaders Network Information Management Committee, also known as lovingly as IMC, Tara Rennicks. And Taryn is the Executive Director of Community Health Centres of Northumberland when she's not chairing the IMC. And so welcome to the stage, Taryn. I saw you moving.
Okay, so I am also lovingly known as someone who dances very much like Elaine from Seinfeld. So welcome everyone. Oh my goodness, I am really hot right now though after that. So welcome everyone to Plenary 2, Futuristic Perspectives on Health, Mental Health, and Artificial Intelligence. That is the last time I'm actually going to say it. Artificial intelligence, everything from now on is AI, okay? In this plenary, we will have a discussion on the current and future uses of AI and technology in enhancing primary health care and chronic disease prevention, with a focus on our marginalized populations. I'm super excited to be introducing our guest speakers. Joining me for this discussion are Doctors Jackie Cooper and Aza Aissa, who are going to come up to the stage, and I'm going to introduce both of them. My apologies, I just received updated bios, and no joke, I am visually impaired, so I'm going to be winging this a little bit. Okay, let's glasses off for this one. Nope, I'm good, but thank you. No, I don't mind declaring. Okay, here we go. Zoom, zoom, zoom. Extreme zooming. Okay, Dr. Jackie Cooper is a senior researcher and epidemiologist, Digital Trials Center at Scripps Research. She holds a pioneering PhD in epidemiology and computer science from Western University and has been acknowledged with the Governor General's Academic Gold Medal. Engaged in AI for health initiatives, she served as CFPC AMS Tech Forward Fellow and focuses on integrating epidemiology and machine learning to leverage value from electronic health records for positive, equitable impact on health and well-being. Welcome, Jackie. This one's on paper. So here we are. Dr. Aza Aissa has joined the Institute for Better Health at Trillium Health Partners as a primary care clinician scientist. She has a multidisciplinary clinical and research background with an undergraduate degree in biochemistry with distinction from Queen's University, followed by a PhD in laboratory medicine and pathobiology, medical school, and family medicine residency, all at the University of Toronto. Dr. Aissa recently completed the Clinician Scholar Program at the University of Toronto Department of Family and Community Medicine. She is interested in advancing primary care research with a focus on social determinants of health, yay, ethical considerations of AI applications, health equity, early detection and prevention, and pragmatic trials involving patients living with chronic diseases. Dr. Aissa is committed to improving healthcare delivery and building a learning health system, Jen Raynor's happy right now, that supports comprehensive primary care and better health for all. Welcome, Dr. Aissa. So we have presentations from both of our guests. I'm going to do a wrap-up presentation, and then we're going to have time for Q&A afterwards. And heaven knows there's a lot of Q&A around artificial intelligence. AI. So let's get engaged with our two guest speakers. Welcome to both of you, and thank you.
Thank you so much for that introduction, Taryn. And I'm getting married next week. I was told I need to practice my dancing. So I think I'm ready now. So thank you for that as well. It's my pleasure to be here and to introduce artificial intelligence for health today. Learning the clicker okay, great. So I want to start, though, with a brief history. And I want to start it before AI was actually a thing, with the idea of a computer algorithm, which is one of the many different building blocks to AI. And the idea behind an algorithm is it's a process or a set of instructions that a computer can follow to complete a task or solve a problem. So you may have heard the term AI algorithm. So what distinguishes an algorithm as an AI is that those things that we're getting the computer to do for us exhibit some sort of intelligence. So fast forward about 100 years, 1956 is when the field of AI was formalized. Now there's a term and a way to sort of bring all different efforts together around the field. In 1972 is when the first medical AI application came out, and this was MYCIN, and this was a rule-based expert system. And so the approach, the sort of methodological approach that we used at this point in time is the idea of we would create a knowledge base. And so we would code, a human knowledge engineer would code facts, collections of rules, if-then statements, and these sort of things. And they'd use logic programming to work through in sort of an iterative fashion. You can imagine kind of like working through branches to get at a final answer, in this case, a suggested diagnosis of an infection. Now, mycin was never deployed in some of these systems. You can imagine it's hard to capture all of the complexity and nuances necessary in the world in sort of a collection of facts and rules like that, but it was still very cool. There's elements of these types of systems still there today. Fast forwarding over a lot of things, including some different ups and downs in AI, the next thing I want to pull out on my timeline is deep learning. And I want to pull it out for two reasons. One is because it made a splash when these types of AI models were beating human experts at different types of games, such as chess or Go. But I also want to pull it out because if we think about AI as a spectrum of different types of techniques, deep learning is at sort of an opposite end of that spectrum to those early rule or knowledge-centric systems. And so the idea with these ones is that data represent examples. And if we learn from lots and lots of these different examples, we can identify patterns that might be useful to do different types of tasks and make predictions and all sorts of cool stuff we'll talk about soon. But I also want to note that part of this advancement in trend toward machine learning and AI being more data-centric was partly because of the methods themselves, but partly because of advances in terms of technology, computing infrastructure, and just the vast availability of data. Okay, 2020, this chart you cannot read, and that's okay, is just showing an exponential increase in the amount of research on AI for health, right? In 2022, now we're taking shorter steps in our history, ChatGPT was released. This represents yet another sort of shift in terms of a new type of method being added in. So the other ones didn't go away, we're just able to do more types of things. And here it's more of a chatbot-like function where we can ask and get content produced back to the user. It's called generative AI. And then the final point I'll just mention is now there's an idea around multimodal AI and advancements being made. Can we get these algorithms to not only work with one type of data, but integrate different types of data together? And maybe then we can find even more complex patterns or do these intelligent tasks even better because, again, we just have much more information available. So what is AI? At its core, there's a collection of different techniques centered around how can computers perform intelligent tasks. This bubble diagram on the right is not complete, not necessarily even totally correct, but I put it up there to make the point that there's a lot of different subfields. They're very intertwined. But if we think about a lot of the AI that's happening today, it belongs to the subfield of machine learning, and at its core, it's math, right? And part of that math is defined by data, right, those examples, but part of it is defined by humans. And not just by the computer scientists, although they have a very important role, but also by other people with lots of different experience and expertise to help define how should these algorithms work, in what ways, and what does success look like. So you should all get involved if you want to. All right, I've said like intelligent tasks a bunch of times. What do I mean by that? I'm going to talk through three main ones. The first one is exploring and describing data. So here's the data. You have a large data set, say a bunch of electronic medical records. We can use AI to find patterns in these data, summarize them. And an important thing, though, is that we're just looking, the machine, the algorithms are looking for patterns. Humans often need to come and ascribe meaning and determine whether or not those patterns can be useful for us. The second main type of task, so the first one we're looking at patterns in a set of data itself. Now we're focused on identifying patterns between some sort of input data, could still be EMRs, and some sort of output. For example, a current diagnosis or a future risk of an event. So again, more prediction type focus. And then the third type is very similar to that previous type, but here in the previous example, each time we're making a prediction, it's like a new instance. There's also types of algorithms that can take feedback. So say there's a recommendation made, say someone is assigned a particular treatment, we see what happens, the results of that get fed back into the algorithm, and then there's an updated recommendation made. So we just went through that top line of sort of three main tasks. People are probably thinking, what about things like language and image data? So we can do all those tasks with those as well, any really type of data. But there's also specialized methods, and we can do other things. And I suspect a lot of people are wondering about generative AI. And so this is the idea that we can now produce new, in quotations, content by using matching patterns that we have learned in the past. And so we don't have much time here with this presentation, so I thought I'd just do a quick little contrasting example. So on the left is the task we just saw, and the focus is on identifying patterns and insights about the input data. So we could train a model, if I showed a picture, it can tell me what type of animal is in that picture. A sort of similar type of task with generative AI is instead I say, give me a picture of a cat, and the patterns that have been used about what a cat is or isn't are then used to produce a picture. Now, this is a tweet from over a year ago, which is a long time ago in both AI and social media history. But I think it gets a good message across, is that, again, they're learning from patterns, right? And so initially, generative AI had a really hard time with hands. Because if you think about it, like pictures of hands, like they're obscure, they're doing weird things, right? And so it didn't know what are the fundamental properties about what a hand can or can't be. Generative AI can now create beautiful hands, but still can make mistakes, and that's really important to remember. Okay, and so we can do all these different types of tasks. We can apply them in all sorts of different ways in primary care. And Aza and Taryn are going to talk about more examples. I want to finish just with one example and more of sort of a story to bring home the point that although we can do many different things, identifying what we should do and how we should do it is super, super important and requires a really big team-based approach. So this is a project happening with the EPIC Practice-Based Learning Network. And we're focused on how can we develop a decision support tool with EMR data from CHCs. And the initial idea, I'm fast-forwarding over a bunch of work to get to this point, but was that maybe we can create a tool that would work in the background of an electronic medical record system. And if a client was newly diagnosed with diabetes, it would try and predict their risk of mental health decline in the next year. If there's a really high risk of decline, then a notice would be given to the care provider, and that might elicit a discussion or different types of care regimes. We were excited about this. We engaged a bunch of people. We got a lot of input, and we were like, we think we can make this work really well, but there's actually a bigger issue. If this tool works, we realized, and we deploy it into practice, we are going to identify either more people that would benefit from mental health services or identify people earlier than they otherwise would have, which in itself is not bad, but we're hearing a lot of mental health services already at or near capacity. So then we just identify a bunch of people that could use help, but we might not actually be able to provide that. So we decided to target a more upstream advocacy and planning type of goal, where instead of predicting individual people that might require help, we want to predict the number of people that might require mental health services in the next period of time. And then if that number of predicted need doesn't match to the planned need, maybe that can be used in different sorts of advocacy and planning initiatives. This is a project underway. We're talking about it more in workshop 6 as well as other types of tools, but I'm going to hand it over now to Aza.
Alrighty, so we're going to follow up on this great talk, and I think it's gonna make more sense and generate some discussion talking about the ethical considerations of AI application in clinical practice and in research. So we're going to start first with taking a little bit of a break and watching this trailer about the problems that AI can generate in the real world. Can we play this, please?
During my first semester at MIT, I got computer vision software that was supposed to track my face. It didn't work until I put on this white mask. I'm thinking, all right, what's going on here? Is it the lighting conditions? Is it the angle at which I'm looking at the camera, or is there something more? That's when I started looking into issues of bias that can creep into technology.
Our ideas about technology that we think are normal are actually ideas that come from a very small and homogeneous group of people.
Vast amounts of data at incredible speeds.
Everybody has unconscious biases, and people embed their own biases into technology.
This kid got stopped as a result of facial recognition misidentification, and then used that as justification to search you. This is an innocent child.
Racism is becoming mechanized.
Systemic issues are only going to be hardwired into new technologies.
It's not just face classification, it's any data-centric technology.
Every day, we are all being scored.
Who gets hired, who gets housing.
I am making predictions for your life right now.
The people who own the code deploy it on other people, and there is no accountability.
Management analytic towers wanted to install the facial recognition software. Pretty much turn this place into Fort Knox.
The technology is being rapidly adopted, and there are no safeguards.
We are socially controlled in a way that we don't see.
Technology that analyzes faces could be biased, but the company is pushing it anyway.
What demographic is it most effective on?
White men.
Show me that it's going to be fair, that it's legal, before you put it out. That's what we don't have yet.
It's going to take people coming together, striving for justice in this age of automation.
Thank you. So if you're interested, you can watch it on Netflix. It's there. I want to just switch to talk about issues of bias in research, and in clinical practice. There are two studies that were released last year and in 2020 that showed that hospitals in the United States and insurance companies are using algorithms and codes that were actually leaving many millions of Black patients behind. This study, I'm going to have to come a bit closer, is showing that. Hello? Excellent. So this study is showing that there is a racial bias and inequity in health risk prediction. If you look at this side, I don't know if I can point. The purple line is Black patients. The orange line is white patients. And the algorithm was based on healthcare utilization, did not account for race, and it meant to find patients that are using the healthcare system more and direct them for referrals and appropriate services to save healthcare costs. What they ended up finding is that more white patients with less chronic diseases were being seen compared to Black patients. So the same code would need more Black patients to have more chronic diseases to be referred. So the risk score basically was inequitable to the patients. And the reason is because the labels on the actual code and the training sets that were used were not correctly accounting for race and were using healthcare costs despite the different behaviors between the two different populations. So this brings up the question, when we design research studies and ask questions, are we basing them on the healthcare system and the available data, or are we basing them on what's happening in the real world? Now, this is just showing the increase in AI and actually the explosion of AI in clinical practice and research. The circles on the bigger circles on the right side, my right, are showing radiology, pathology, which we know that the computer vision softwares are excellent. They have improved practice, they have reduced inefficiency, and allowed physicians to focus on images that needed to be detected earlier. So the computer vision softwares can detect even minor benign cases, and then a physician can review them. But let's think about primary care. The circle is increasing, so 223 studies by 2020, and this is just searching PubMed. What are these studies on, and what are they using for AI? So one thing that I always think we need to think about, what is our source of data? So in primary sources of data, whether you're using an ECG or an X-ray or a dermatology slide, you're actually directly looking at the slide. It's the researcher who's asking the question or the patient, and you know what you're working with. With secondary use of data, despite the fact that it is very useful in improving clinical practice, in enhancing healthcare system evaluation and healthcare utilization, and in research and innovation, we have to also think about why was this data collected in the first place. So the data sources can be very variable. They can come from medical claims, they can come from pharmacy claims, from OHIP, they can come from wearable devices. So we have an abundance of data sources, but do we have a standardization of how we use this data? So I like people to think about the tool design and development, to consider who will this tool help, what type of studies were used by this tool, and who's able to access this tool, and who will use it. So basically, the problem with the current AI technology development is that we're becoming very good at solving data problems, but yet still poor at solving real problems, i.e. we're becoming very good at data cleaning, at generating good data sets with more information, but generalizability and applicability still lags behind. But in order to achieve that, the first step is to solve the problem. So we need training AI tools. And Jackie explained that in a lot of these AI tools, you need to have a training data set, and then you have a validation set. So if your training data set is lacking diversity or is a small set, you're going to come up with terrible AI algorithm and a model. Now, we need a large and diverse data set, but we don't have self-reported race data or equity data in socioeconomics in Canada. So how are we going to be able to actually be developing fair AI models? How could AI harm historically disadvantaged populations? Now, despite that I'm saying all these negative things about AI, we have to realize that the starting point of artificial intelligence is always human intelligence. And that machines can be also discriminatory, they can be racist, they can be sexist, and yes, we have lack of diversity in data, but also we need to include diversity in AI developers, because then we will make sure that we have specific checkpoints in terms of not having judgmental data sets or having AI biases in healthcare. Now, also co-design is needed to make sure that the questions being asked are not biased. The data collected is not biased, and the analysis and the interpretation of the data is not biased, thereby creating biased cultural storytelling or narratives that are going to worsen inequities. So we need regulation, and we need to take into account privacy, accountability, and commitment to act when we identify these inequities. Now, let's talk about primary care for a second. We're the gatekeepers. We are the people who care about patient-centered, value-based care. So why do we care about AI? Because while we're not sure how it can change our practice, we know that it will. In the same way that electronic healthcare records change practice for many family physicians and clinicians. So we need to be aware of the advances and see how we can apply them in a way that values patient privacy and patient-centered care. And we need to also realize that we have a strength. We have the comprehensive longitudinal care ability with our patients, and we also have breadth of data that are not just organ-specific with specialist care, cardiology, radiology. No, it spans different organ system, mental health care, home health, long-term care, so different organ systems and different healthcare system utilization. That's the strength of primary care that no other fields have. So let's say you're a clinician and you read a paper on AI. What should you do? Where do you start? So here's an approach that you can use. You can evaluate AI studies as a clinician by first asking, is this relevant clinically? Can it enhance my practice? What is the data used? What's the data quality? Is there rigorous methodology? Did they actually report on the quality of the data? And was the result robust? Did they have a validation set that confirmed what the training set had? And is it reproducible? In other ways, 3 important things. Quantity, did they have a large data set for their training? Quality, where did the data come from? Does it have health equity measures? Does it account for social determinants of health? And diversity, is it representative of different groups, whether ethnicity, socioeconomics, age, gender, etc. So I talked a lot about the ethical considerations of AI. Let's talk about the strengths of AI tools for primary care clinicians. AI Scribe would be an example. It has been utilized in the United States in many clinical practice to enhance care and allow clinicians to have more face time with their patients. It reduced clinical admin burden and burnout. So it does have a potential of enhancing comprehensive, compassionate care. Another example is detecting falls in the elderly. We have a huge problem with chronic diseases and aging population, and it can help with remote patient monitoring. So there are wearable devices, cameras that can detect elderly falls, and this can be traced back to whether in long-term care to the nurses or to patients and family members. So this is another application of AI that can actually enhance compassionate care. They did a study or a poll in Facebook and social media to see doctors' perception on AI versus patients' perception in AI. And it was interesting to see that actually physicians were more resistant to AI than patients. Physicians thought that it actually is added a burden on figuring out the tool and wasting time dealing with technology. And patients thought that they care about trust and the fact that their confidentiality is not breached. However, it could actually enhance their care and make them able to save more time. The study on the other side is an important study that I absolutely like because it talked about we have made huge progress with computer vision, with enhancing reads of ECGs, cardiology, and chest x-rays. But this is doctor-centric, or at least health system-centric. What about AI detecting patient experiences? An example would be osteoarthritis of the knee. You can have two patients who have the same x-ray that shows mild to moderate severity, yet one patient experiences significant pain compared to another. So they developed an AI tool that can predict patients' pain and experience and can actually help them get referral to orthopedic surgery for knee replacement. So there is a huge room for AI improvement if we ask the right questions and we actually involve patients and involve allied health professionals. So the intent of AI, at least this is my belief, it's not there to replace clinicians. It is there as a tool to add to our clinician toolbox, but no matter what, evidence-based data and shared decision-making remain the cornerstone of understanding how we can help our patients. So clinical evidence and shared decision-making is not the model output that ultimately will tell us whether the AI intervention has had a net effect to the patient care or the healthcare system or not. Again, clinical evidence and shared decision-making will precisely tell us for whom and under what condition the model provides benefit and for whom it will not. And it will tell us whether we have made healthcare delivery more equitable or not. So I touched on this. There are many reports of lawsuits regarding secondary data use without consent. We need to be careful about healthcare data, institutions, and commercialization of the data, liability and accountability. And again, I'll come back to the fact that it starts from the design, from the coding, inclusive coding, who codes matter, how they code matters, and why they code matters. So it's an ongoing debate on who will be held liable in the future if the robots and the AI start acting autonomously and end up harming patients. So we need to ask ourselves, if we're doing co-design with AI studies, what do my patients, providers, team, and organization value in the way they access or provide services? Does the AI technology align with these values? How can we adjust our technologies or processes to ensure they do? And what regulations are in place or should be to mitigate the risks and biases? And I'm almost done. Co-designing studies and implementation. Again, I mentioned that. Identify the data source. Is it primary, secondary, or tertiary? Co-design and engage in an iterative development of the AI tool and implementation. Aim for understanding and inclusion. AI is not there to make the diagnosis or to predict what will happen without human input. And take into accountability the key concerns for historically disadvantaged populations, including data ownership, data governance, and privacy considerations, especially if you work with indigenous and Black populations. There are many frameworks, including for the Black populations, the EGAP framework. And I'll end with this. Big data and artificial intelligence will revolutionize healthcare. The question is how? And to realize the potential of AI, more fundamental issues need to be addressed. Who owns the data? Who is responsible for it? And how will it be used and who can use it? Cloud computing alone will not answer these questions. Public discourse, engagement, and policy intervention will be needed. Thank you.
Okay, my turn. Oh, no, that wasn't supposed to happen. You're not supposed to see that. Oh, I'm devastated now. Okay, so why and how am I, a new-ish executive director from a mid-sized community health center in rural-ish Ontario, how am I going to add to what we've just learned from these two experts? Thank you, Jackie and Azza. That was fantastic. What I'm going to do now is I'm going to take everything we've just learned, and AI is a real hot topic right now, and I'm going to bring it into our organizations. So whether you are here representing a community family health team, a nurse practitioner-led clinic, an Indigenous primary health care organization, or a community health center, there are so many things we need to consider when you take all of this amazing information and think about it in our organizations and our day-to-day life. As organizational leaders, we have a lot to consider, but think about the other pieces of the puzzle: health promoters, social workers, primary care clinicians, IT professionals. I know we have a lot of board members in the room. What do boards have to consider when we're talking about AI in our organizations? And most importantly, how does this impact our clients? That is the big question. Implementing AI is a big deal, and everything moves so fast, and that's why I'm so upset that I disclosed that slide early, because I want to take you back. I want you to consider where we've come from. Okay, everyone pretend they didn't see that. So this is where we've been, right? The Stone Ages. So taking you back to the Flintstones. The Flintstones had little to no technology. I recall a little pink elephant being a vacuum, literal rabbit ears on top of the television, right? You get the picture. Well, none of us in this room are actually from the Stone Ages that I'm aware of, but when I heard there were 600 people, I thought, maybe. We have come a long way, and many of us worked and lived pre-internet, pre-electronic medical records, pre-cell phones, and certainly pre-artificial intelligence. Having said that, Jackie did allude in her presentation to the first instance of AI in healthcare in 1972, which is absolutely fascinating to me. But before any of these technological advances, in 1962, good old Hanna-Barbera Animation Studio was dreaming up the following. Okay, so this came out in 1962, but guess what? They were thinking 2062, which is exactly 38 years from now, and God willing, I'll be 87. But I'd like to point out that Rosie the robot, that's AI. They had flying cars, we're not there yet, but we all know, let's look at the last 10 years in the automotive industry and how far we have actually come. It's incredible. But in the Jetsons, there were so many smart devices that were controlled literally with the touch of a button. So we know the AI revolution has arrived, and it has arrived everywhere, including the healthcare sector. It is now penetrating the far-reaching but perpetually underfunded, preaching to the choir, world of interdisciplinary primary care. Having said that, as a sector, we know that we are progressive when it comes to data collection, adhering to legislative requirements, a good example being privacy, and technology and digital health advances. I'm now going to share with you quickly 2 examples of AI that we've experienced at the community health centers of Northumberland. The first is that we have a physician piloting a Canadian-based AI scribe program. He's very tech savvy. He's very good at getting appropriate consents from his clients. And he understands that there are follow-up requirements to ensure accuracy of his notes within the EMR. I had the opportunity yesterday to sit down with this physician and do a mock-up. So I was a dummy patient. And so Taryn Rennick's presented with chronic headaches for the last 2 months, occurring on the left side of my head for many hours, and about 4 times a week. So the physician asked me the appropriate questions. We had a great dialogue. and he actually looked me in the eye. Okay, he got my consent to use AI scribe tools, and he looked me in the eye. He wasn't doing this or this while he was talking to me. So that was the first thing, the interactivity I noticed. That was the first thing I noticed. Secondarily, after we had our encounter, we simultaneously reviewed the EMR note in Practice Solutions, and it was bang on. That is not always the case. I don't want there to be a misunderstanding that that is always the case. It certainly is not. That is why there's a requirement for review. But my goodness, it was incredible. Then we reviewed a potential referral letter to a specialist, a headache clinic. And then we referred a client summary so that I could go home to my partner, my family, and I could say, this is what I talked about. And he could hit print, and there we are. Review is required. This was a bit of an anomaly in the sense that there was absolutely no adjustment needed. We did decide in the end that stress is the reason for my headaches. I was very nervous about this. So that's one thing. The next instance we had with AI recently, and I'm watching the clock here and I'm starting to panic. The next instance we had, strategic planning. We're all doing that in our organizations on a 3 to 5 year cycle, right? We hire consultants. We engage with our stakeholders, our clients, our partners, our staff to develop our strategic priorities. So we were going through this process, and one day, one of our very tech-savvy board members came up to myself and our board chair and put a pile of papers in front of us. Guess what? He asked ChatGPT, I'm not kidding you, what should the strategic priorities of a community-based interdisciplinary primary care organization in Southern Ontario be? And we had pages upon pages of strategic priorities. I am not recommending this, by the way. But honestly, our immediate reaction was the horrors. Like, what about the engagement piece? Having said that, I want to highlight something. It wasn't horrible. So, those are 2 instances of AI at a community health center in Ontario. Big data and machine learning are having an impact on most aspects of modern life. Netflix knows what I want to watch. Amazon sure as heck knows what I want to buy. It's usually shoes. And Google, oh my goodness, Google knows everything. Google's no longer a noun, it's now a verb. I'm going to Google it. Okay, but are we there yet? Are we there yet? Raise your hand if you're ready for AI in your organization. Fascinating. Okay. So we know that AI has the potential to significantly improve primary health care by enhancing diagnostic accuracy, personalizing treatment plans, optimizing workflows, and improving patient outcomes, which is really what we're looking for. But to fully realize these benefits, a very thoughtful, a very patient-centered approach, and a very calm, collected, probably time-consuming approach to implementing AI in primary healthcare can lead to better outcomes and a more efficient healthcare system. Now I want to talk about the considerations. I am so close to being done, but I think there's a lot of really important considerations for our organizations. AI in primary healthcare offers so many benefits, but it also comes with challenges that we need to address, and these are some of the questions I think we need to ask ourselves. How do we ensure data privacy and security? We call Mark Gordon and Simeon Kanov at the Alliance. What are the risks to our clients and our model in the use of AI when, as we've just heard, bias clearly exists? And how do we mitigate those diagnostic errors? Can our regulatory and ethical standards keep up with the advancement of AI in healthcare? At this point, I would say no. It's moving very, very quickly. Big question, are our clinicians and providers ready? Lots of training, lots of new thinking and workflows. I probably should have put this question last. Can we afford AI? Can anyone answer that question? And recognizing the number of board members in the room, is your board risk adverse or risk tolerant, right? Because there are risks that come with this. So mitigating these risks is important to implement robust ethical guidelines, ensuring comprehensive training for our healthcare professionals, developing inclusive and representative data sets to prevent inequities, and establishing rigorous regulatory standards. Balancing the benefits and risks of AI in primary healthcare requires a careful and thoughtful approach prioritizing patient safety and health equity. In closing, I want to thank our two speakers, Jackie and Aza. Thank you so much. We're going to do some Q&A, I believe, in just a moment, but I do have one more comment. This feels new, sometimes it feels scary, but I want to remind you that just a few years ago, it was new to us to do virtual appointments, and we had a lot of questions and concerns about that. But guess what? Zoom was invented in 1962 by Hanna-Barbera. Thank you.
Thank you very much for, I have a lot of questions in my head, but thank you very much for great presentations and discussions. Maybe it's time to have some questions or comments that we have. There's a light reflections here, I can't see on this side. Michelle.
Yes, thank you. For starters, you know, when you used to don't Google yourself, don't ask ChatGPT to describe you either. So just, it's a fun little exercise if you want to do it. But one of the questions I have is that I absolutely see and believe in sort of all the kind of within the medical, and I think it's a bit of an easy one for us to sort of take a look at. What I'm really curious at when we started talking about AI and looking at what an AI policy would look like in our organization was the realization that it was already here and what implications did it have. So we have people using in our own organization things like Otter AI and Read AI, taking notes and scribes in meetings. We have people using ChatGPT for all different kinds of pieces that we're not even aware of what's happening in staff using it across the whole organization. And so what I'm really curious about is you both have presented really effective kind of stories about where the bias might be happening in medicine and healthcare in perspective, but it's actually already embedding and shaping, I'm sure, the things without even necessarily knowing because people are using it, and not everybody is saying, oh, I used ChatGPT to design X, Y, and Z, or my note summary is coming from Otter AI, and so what is it picked up on? And so, organizationally, I wonder if you have any thoughts about, so then, what conversations do we also need to be having broader in our organization, because people are using it the way you use Google without necessarily thinking about some of these ramifications. And it's easy to design an AI policy for, not easy, but I think it's more obvious around healthcare stuff, but the other stuff that people are just like, but this is just now part of my regular toolkit, like spell check on my Word, but it is much more insidious. So I know it's not a clear question, but I'm grappling with this because it's already so deep into our systems, it's already down there, so.
Is it on? Wonderful. Great. It's a great question. And I'll start off and then Azza, you can add on. I think I have a couple thoughts. I don't think there's a well-known one right solution to start off, right? A lot of people are wrestling with these same questions. And so I think it's good to start asking them and the discussions and learning from what different organizations are doing. I think one key distinguishing factor is the AI being used to impact client care delivery? Because if there's questions around consent and transparency about that. So there's a distinction between, is it going to change someone's care regime or interactions with the system versus is it someone doing their own job on their own, where if they would, Google something and then use it, and they're also like looking at what the outputs are and overseeing it. Because at the end of the day, to know everybody who has ChatGPT on their phone and how they're using it is just not realistic, and it's so pervasive. But if it's being used to come up with someone's, treatment plan, that's a very different story. So that's one distinction I would think about. And then the other one is around just general education and awareness. And I think having open forums for discussion, but also there's lots more like online courses that are being developed. Like I do think there's an education and a capacity piece, and that's to the point that was like, I don't know how people are using it or if they're using it properly. Again, like as these things become more and more pervasive, it's important that everyone has a certain level, for example, that mistakes are made. And if people are checking for that mistakes, that's great. But if people don't understand that mistakes can be made, that's a different sort of issue.
Yeah, I think there are two important things to keep in mind. Creativity is not going to be something that ChatGPT can do on its own. So I always think of it as a starting point, but the creatives are going to be okay. The problem is going to be in education and in research is plagiarism. So a lot of the talks in education in like graduate school, et cetera, is the realization that ChatGPT brings its information from, again, the training set that people put into it. So if you're a graduate student and you're doing a thesis or a master's or a PhD, don't try to edit it in ChatGPT because it's probably there before you publish it. So the realization that what you're going to take out of ChatGPT may be new to you, but it's not necessarily new knowledge to everyone else. So people can actually pick and like they can realize if it's something that is completely ChatGPT versus you put some effort into it. So I think, again, it's that fear of like AI is going to take over clinicians' jobs. Oh, ChatGPT is going to make creatives go away. I don't believe in that because, again, artificial intelligence starting point is human intelligence. It didn't create itself. Somebody created it with the training sets. That's my own opinion. I think, again, regulation is going to have to come into place. Different organizations are going to have to make their own policies regarding how they come up with their strategic plans. But I'm not the expert when it comes to that, but that's what I hope they would.
Thank you. Can we go to mic 3 and then I'll come to mic 2 afterwards?
Hi, thank you so much for an insightful presentation. I just had a comment and a question because recently we used the PoppyBot for innovation piece around cancer screening, and there were some learnings that we had out of it. And I'm just wondering that maybe I had a particular interpretation from the presentation, but are we saying that AI needs some level of EDI embedded in it because there's larger systemic issues that do get influenced when we are using AI? And it seems like, and in my experiences, that it's great at collecting data, but like you can have the wrong analysis coming out of it as a result of the bias that exists. So I'm just wondering, we have to ask ourselves who, in the end of the day, like controls the levers or the arms of health innovation, and what are your thoughts about that? Because there is a lot of, how do we ensure basically like the data that we're collecting is not being controlled by monopoly corporations, which we have seen in the recent, I think there's a lot of pieces out about Judy Faulkner and how that innovation piece has been like the most prominent. So how do we make sure that advocacy is still maintained and that's at the forefront? And if you had any thoughts about that. So yeah, we can maintain health equity as the main goal. Yeah, thank you.
Thank you.
This is a great question, and it has many different aspects, so I hope I answer it fully. I think, again, the co-design piece is really important in this aspect. I think the data, whether we like it or not, it's going to get collected. It's just a matter of how and when and how quickly. But I think it's almost probably would benefit us more to let's assume that we're going to collect the data, and hopefully there will be some regulation, because we are calling, like we published in CMAJ, talking about collecting health equity data during health card renewal. So it's a central one way of collecting the data that can be applied to everyone equally versus each organization collecting it in whatever way they want. So regulation is important, but I think when it comes to application, which is the important piece, which I agree with you, whether in research studies, in clinical practice, the interpretability and the explainability. So let's say an AI detects cancer in a CT scan, or an AI research study says this group of patients should be seen faster by this specialist, etc. There has to be a validation set and a human person reviewing that. Because we see also, like, computer vision can pick up a lot of things that it shouldn't pick up, and they're benign, and it ends up in actually more investigations and patients going through a lot of stress, etc. So it does have the benefits and the risks associated with it, and that's why validation and explainability by a human person is needed. So,
yeah, and maybe I'll just add on to the point about bias ending up needed. Like, AI in and of itself is not biased, right? Like, these are just tools and techniques. It's learning this bias. Often systemic biases and human biases have worked their way into data. If we're aware of those, we can do things about it, right? In any given tool, and we can check for them and evaluate for them, and even maybe identify biases and barriers we didn't know were there before, right? Through a really intense team-based development approach. It's when we're not aware and not asking the questions and don't know the biases there, that's when the real risk is, because that's when things make it past all the checks and balances into practice and can start hurting people. So again, awareness is power, and you don't need to be an AI expert to help inform what are the things we should be checking for to make sure that we don't deploy things that aren't ready yet.
Thank you. We have 2 more questions, and I'm out of time. Okay, I'm being told mic number 2. We'll ask the question, and we'll see if we can go to question 3 or not. But time is of essence here, so.
Okay, so I'll
go
go
ahead,
really quickly. I'm a family physician. I work in a community health center in Ottawa, Centertown Community Health Center. My wonderful ED has been entertaining us this morning. And actually, that has a huge amount about what I want to say about my questions about AI. So I've been using it for the last few months. I have a very diverse practice, and I have a practice where a lot of the social determinants of health actually hugely impact their healthcare. What I find that the Tally AI does is it gets rid of them all. So I may have a 20-minute conversation. I might have a similar conversation about the headache, that's probably one of the more common ones, with 3 very, very, very different patients. Tally AI is going to give me a very similar note on all 3 of them. Now, I know that I have to go in and edit because I use the translation quite a bit, because I speak both French and English, and because a lot of my patients are using interpreters. But I'm trying to figure out how to add those je ne sais quoi, those things about the patient that allows the next person who's going to read my note to know that these 3 people were not the same. We can talk a lot about judgment and how judgment influences us in healthcare, but judgment is actually really important if I'm going to take into consideration how that headache is different according to the social determinants of health. So I'd love thought. The question is, how are we in the community health centers going to get AI to bring in the social determinants of health, because it's not going to put it there?
Great question.
Sorry, that was slow.
That's a great question.
Is your question related to kind of this? Can we add it to the question briefly?
Sure, it's not really a question, it's more of a comment. And as I sit here...
I'll give you like 30 seconds.
That's fine. The comment is let's not forget, as we sit here in this room through many different professionals doing many different things, that there's a person that is sitting in front of you, that trauma-informed care is important, that it should be heard. We already know that the diversity and the minorities are not being heard. And until we actually address those concerns and align them with the steps that you said, if we don't know, then we can't fix it. Well, we've been asking questions around cultural competency, diversity, and health equity for years. We are asking questions, getting answers, but truly, what are we doing about it? Have we moved the meter? So before we move the Jetsons, into this world. Let's take a serious look
Thank you.
about what that looks like and how we keep the human experience alive. One last thing, if you are an Indigenous person that is walking into a room that is incapable because of historical imbalances to understand how to operate this thing or other things, you're going to have a shut door in your face. If I don't believe in you and I can't trust you, I'm not going to trust AI.
Thank you. Thank you. So quick response, comments, and wrap up as well at the same time. Thank you.
Sure, I'll go quickly. So a lot of really great points made there. I think one thing I want to flag is it's excellent. The awareness that the tool that's being used is not picking up on the social determinants, like that's excellent, and that's so important, and that's an example of the way that these things can be used responsibly. I can't speak to particular tools and development processes because I don't actually know that much about all the different ones, but one of the things to keep in mind is, right, it's learning patterns from the past. So if it's learning from data sets and other encounters from different types of systems where social determinants were not prioritized as much as the member organizations in the alliance, that's why it's not being picked up, because it hasn't been an important pattern in the past. That can change and improve over time. And so the awareness and the fixing and sort of the code development, I don't know how well it works with different sort of vendor-based tools, but that's sort of why that's happening, and one of the things that can be done is being aware at that input. The other point is that, like, for example, the project that we're working on with the practice-based learning network is social determinants are collected in a lot of EMR-based data, and so we are using them to inform the tool that we're being developed. Obviously, not all types of tools can be developed, but it's not that it can't be done, right? It's who's at the table, who's informing the problems, and are the data available to work them into play. So, yeah, I'll stop there.
Yeah, it's exactly that. The reason why it's not mentioning the social determinants of health, because there was no interest in collecting health equity data in a lot of the AI developing world. And that's part of the reason why now there is a little bit of more interest in health equity in that field of AI, because they're realizing that obviously it's not picking up all the important information. And I agree, trust and human interaction is needed, but as primary care clinicians, if we don't embrace the existence of AI, we won't be able to influence health equity and centralize it in the AI technology. So the reason why we need to care about AI is because we need to steer it in the right direction.
Final word in 10
Really
seconds.
quickly, I just want to add for everyone, and thank you both. That was fantastic. Jackie, good luck at your upcoming nuptials. Very happy for you. Just want to add, much like we did a couple of years ago at Information Management Committee when we added cybersecurity to our regular standing agenda, guess what? Artificial intelligence is now on the agenda regularly. So we are going to be doing this work with the Alliance team to make sure that we get these answers so that we can implement in the proper way. Thank you.
All right. Please extend your gratitude to Taryn, Jackie, and Azza for a wonderful presentation and conversation. So thank you. All right. Okay, thank you. I had a question, but I'll ask some other time. But now I get the privilege and honor to introduce the next speaker. I consider a good friend, an elder, and I'll ask for Elise Harding-Davis, a member of the Alliance Board, who will join us on stage now to present the 2024 Community Health Champion Award. I think it's the first award being presented, so please welcome Elise.
I prefer peer, but I'm really honored to be here today to present this year's Community Health Championship Award. At the Alliance, we recognize...
Elder is not about numbers, you know, it's about...
It better not be. At the Alliance, we recognize that our work would not be possible without a strong network of partners and supporters. Those partnerships are rich and diverse and encompass a wide range of organizations within the health, social, and community services sectors. The organizations that work along the Alliance and Alliance members to advance equitable health and well-being for everyone in Ontario. They also include media, whose work contributes to raising awareness about issues important to the Alliance and sharing stories of solutions that work. Each year, the Alliance Board recognizes their incredible work with the Community Health Champion and Media Awards. Before we get to presenting the Community Health Champion Award, I would like to say a few words about the Media Award. This year, the board nominated Sarah Law, a CBC correspondent located in Thunder Bay. Sarah could not accept this award because of CBC guidelines. Still, we want to acknowledge her excellent journalism covering a wide range of important issues that impact the health and well-being of people in Northern Ontario, including Indigenous health, food security, housing, and climate change, among many others. And now, over to the Community Health Champion Award. We are excited that the recipient of this award is able to be with us today and will soon join me on stage. A peer. The Community Health Champion Award acknowledges and celebrates outstanding contributions to the community health field. Past recipients of the Community Health Champion Award include Senator Murray Sinclair, Carolyn Ledstone Jones, sister, CEO of the Indigenous Primary Health Care Council, overdose prevention sites in Toronto and Ottawa, the Ontario Oral Health Alliance, the Black Health Alliance, among many others again. This year's recipient definitely is an amazing addition to this inspiring list. Rainbow Health Ontario is a program of Shelbourne Health, and its aim is to create opportunities for the healthcare system to better service Two-Spirit LGBTQ+ communities. Rainbow Health Ontario offers training for healthcare providers across the province to build their clinical and cultural competency in caring for the Two-Spirit LGBTQ+ clients. It also supports system change by providing evidence-based resources and contributing a Two-Spirit LGBTQ health perspective to public policy processes. Rainbow Health Ontario acts as a research catalyst and hosts Canada's largest Two-Spirit LGBTQ+ health conference. Rainbow Health Ontario's work includes building capacity for trans health across Ontario through clinical and cultural competency training, mentoring, and fostering networks, as well as resources and consultation. Huge, huge, huge. This program also connects Two-Spirit LGBTQ communities to LGBTQ positive services through a service provider directory. Rainbow Health Ontario's work aligns with the Alliance's commitment to advance health equity for Two-Spirit LGBTQ and other sexually and gender diverse communities. This commitment is embedded in the Health Equity Charter. LGBTQ+ Two-Spirit communities are also recognized as one of the Alliance's priority populations. The Alliance for Healthier Communities and Alliance members continuously rely upon the resources produced by Rainbow Health Ontario. including its bilingual Two-Spirit LGBTQ Foundations course. We're grateful to have Rainbow Health Ontario as a partner in working towards equitable health and well-being for everyone in Ontario. And now, please join me on stage, Sil Hernando, Senior Program Manager of Rainbow Health Ontario. Welcome, Sil. Thank you for being with us to receive this award.
Oh,
And we'll do this and we'll do a photo op. Stand here and act like we're really.
Thank you, everybody. It will, okay, it's gotta go this way. Otherwise I'll drop it and break it and then my team will kill me. All right. Thank you so much. I am honored to accept the Community Health Champion Award on behalf of the Rainbow Health Ontario team. We want to thank the Alliance for Healthier Communities for recognizing our long-standing work to ensuring us LGBTQ people have access to culturally and clinically competent healthcare services. I'm a little emotional. I did not expect that. I also want to thank my team who are not here. They are hard at work because it's Pride Month. For their commitment to our work. I'm proud to lead a team that works to change the world every day. We are a small and mighty team, and I'm not going to repeat everything that was just said about what we do. I'm just going to add two things. One is that we have trained more than 50,000 healthcare providers over the last 15 years that we've been around. Thank you. And this year, we produced our first podcast, 4 episodes. Please check us out on knowledge sharing for us LGBTQ people for providers in healthcare. So I think you will find it quite interesting. This award couldn't be timelier. Right now, our communities are under attack from anti-trans forces looking to prevent us LGBTQ people from accessing evidence-based care with the ultimate goal to exclude us from public life. There is a rising tide of misinformation and disinformation targeting trans people in particular, and our rights, especially the rights of our youth, are being put into question. Healthcare providers are experiencing harassment, and there is a chill across our sector when it comes to openly and proudly caring for us LGBTQ people. This attack isn't isolated. Our communities are seeing the increase of racism, the challenge to reproductive freedoms, the scapegoating of poor and working class people. The list goes on. We are not just queer or trans. We are refugees, we are parents, we are neurodiverse, we are racialized, we live on the streets. Our identities aren't monolithic, and neither are the multiple communities we may belong to. Our struggles are inextricably linked, and so are our victories. Awards like this help us to keep going. We hope that you'll join us in creating a more just world by improving access to care for us LGBTQ communities. Take a course with us. read our numerous resources, let people know that you support 2S LGBTQ people, provide the care that our communities need. Reach out to us if you need help knowing where to start. And together, we'll continue to make sure that everyone has access to equitable, timely, life-saving care. Thank you.
I just want to thank you, Sil, for sharing your thoughts. And then I told them I'm going to make them cry with the next thing I'm going to say, too. Because many of you might not know, because as I look around the room, I know that there's not many people who were in the original room with me when in about 2005, 2006, RHO and Sherborne Health Center called a number of community health centers that they knew were 2S LGBTQ positive and doing some of the work, and said, will you help us bring this culturally competent and clinically appropriate care out to other people across the province, because we know people are traveling. And so we came in, the Alliance actually supported our travel, and I remember sitting in the boardroom with, I think there was maybe 6 of us, but I only remember a few. So Sheila Bradick was there, she was at Kitchener Downtown CHC. Wendy Talbot was there from Norwest Community Health Center. I was there from London Intercommunity Health Center. And Simone Thibault, my predecessor in Centretown Community Health Center, was also there, and there was a number of us. And we sat around the table, and there wasn't any extra money. And we didn't know how we were going to do it. But we all went back and said we were going to support our staff in getting training, and we were going to try and figure out how to do it. And now, most of those centers all have very large, very significantly serving supports in their community for trans health and non-binary supportive services, so past that capacity. And also many of us are continuing to build that capacity and support and continuing to grow. So the impact and the partnership has been beyond those 50,000 and has ensured that that leadership shown close to 20 years ago, actually, has ensured that there are reasons why there is trans health, culturally and clinically appropriate care available in community health centers, nurse practitioner clinics, and why some of those CHCs that were funded at that time actually became focused on queer health services. So thank you to RHO for leading the way and supporting us all the way back then. I am also the chairperson of, one of the co-chair persons of the 2S LGBTQ plus community committee at the Alliance. And one of the things that is regularly on our minds and that you will see us calling out in the bulletin is, as Sal said, is that 2S LGBTQ rights are under attack in the United States. They are also under attack here in Canada, as Sal has shared. And I regularly spend time with my Rainbow Health employee resource group at my organization, working through a number of real issues of fear and safety for staff and for clients. And so when we put the call out for you to show up and please speak out on your platforms about what's happening, please respond and support us. With that, I gotta shake that off for just a little bit. I just gotta shake that off just for a little bit. It is now time for a break to visit our research poster boards down the hallway and just outside the Richmond rooms. So there will hopefully be many of the study leads who will be on hand to take your questions out there. It's a great way to have interactions. It is a 3 p.m. start on the learning sessions, so just a reminder to show up by 3 p.m. for the start, and show up early and only show up for the sessions that you've registered for. I saw a bunch of people standing outside of rooms disappointed because capacity is full. I'm still talking. I have more important information to share with you. Tell you. Thank you, Elise. Tell you. Well, then I need to tell you something really important, which is about thanking our volunteers. We are halfway through the conference. Our volunteers are at the back. I think that we've got some volunteers back there in the yellow. If you're a volunteer, stand up. Stand up. Thank you. Green lanyards. Thank you. Thank you so much to all of our volunteers, and thank you to the centers who have freed up their time to support this. We could not do this without the volunteers here today. I've had some people come, and as I was walking by the exhibitor booths, I had a number of people, I'm talking to them, I'm not just getting them to stamp. Excellent, I'm glad I put that fear in you, that I am monitoring and I am following around, and that's excellent. So remember, get that filled. If you come in and it all gets filled, you can drop that off at any time. In Plenary 4, we do the draw. You have to be here for it, so, it'd be a shame if you went through all of that and you didn't stay. And then please continue to do the hashtags on social media. Send those posters out. And then tonight, quickly, I want to remind you about the gala. The pre-cocktail receptions with cash bar starts at 4:45. The doors open. Do not try and get in early. But the award ceremony starts at 5:30 on the dot, followed by dinner at 7:30, and we will MC. I'm not MCing tonight. We have a brand new MC, Coco La Reine, who will be looking forward to celebrating with you tonight. Dancing, of course. Get those dance moves from Tamara on this morning or your own. And we will see you tonight. Have a wonderful day. Bye.